Hello, everyone. Welcome to today's live broadcast, Urine Drug Testing and Pain Management, presented by Dr. William Clarke. I'm Christina Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. For more information, please go to www.labroots.com. We have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to get to as many questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing the presentation, please click on the support button on the top right of your presentation window, or submit your problem through the green Q&A button on the lower left. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located on the bottom left-hand corner of your webpage and follow the process of obtaining your credits. I would now like to introduce today's speaker, Dr. William Clarke. Dr. Clarke received his PhD in analytical chemistry from the University of Nebraska in Lincoln in 2000, followed by a postdoctoral fellowship in clinical chemistry at the Johns Hopkins School of Medicine, ending in 2002. In addition, he received an MBA focused on medical services management from the Carey School of Business at Johns Hopkins in 2007. Following his postdoctoral fellowship, he has remained at Johns Hopkins, where he is an associate professor in the Department of Pathology, as well as the director of both point-of-care testing and clinical toxicology for the hospital. Dr. Clarke is board certified in clinical chemistry by the American Board of Clinical Chemistry and is a fellow of the National Academy of Clinical Biochemistry. I will now turn it over to Dr. William Clarke for his presentation. Dr. Clarke?
Thank you, Christina. So I appreciate the opportunity to speak today, and we'll go over urine drug testing in pain management. Before I begin, I do need to show my disclosure slide. Pain management testing is heavily dependent on mass spectrometry as a technique for measurement. We'll talk more about that later. But I do have the two disclosures that are pertinent, research and consultant support from Thermo Fisher Scientific and Shimadzu. So I want to start this afternoon by talking a little bit about the treatment of pain, as this is becoming increasingly important in our society and in clinical practice. So when we think about the pain management patients, we want to think who are these patients, and it comes from a wide variety of places. We can think about issues with folks from central nervous system derived pain, folks with multiple sclerosis or Parkinson's disease. We have neuropathic pain or arthritic pain. A lot of folks have chronic pain, both cancer-related and non-cancer-related pain, and then we have fibromyalgia. Depending on where you go to get your statistics, you'll see I have something listed here where we say in 2002, almost half the U.S. adults, or a little over 40%, reported experiencing pain for over more than 1 year. Some of that's just a consequence of getting older. I find myself a little stiff getting out of bed in the morning once in a while, and so some of that is dependent on pain tolerance. But what is definitely obvious to us is that more and more people, as we increase our ability to manage chronic disease, also we see more chronic pain. So when we think about chronic pain, physicians in many settings may treat one of several opioid drugs. We have Oxycodone or Oxycontin, we have methadone, fentanyl, Hydrocodone. And the thing about the opioid drugs is that they have a high potential for addiction or abuse. And so this is a challenge for physicians because they are treating this medical condition of chronic pain, but they're also giving a drug that definitely can be abused, and in some cases where patients may misuse the drug by keeping extra portions of it to themselves and then taking large boluses of it as opposed to taking it in multiple smaller doses, or they may divert it, right? In this case, what they may do is say that they have pain, they keep some of the drug for themselves and they sell that to either support a different drug habit, or it may be non-drug related behavior. The other issue in pain management patients is that the physicians need to know whether the patient is taking non-prescribed drugs during treatment, as this can both be an indication of drug misuse and abuse, but it also can be problematic in terms of patient safety because of drug-drug interactions. If a patient is taking an opioid drug such as oxycodone or fentanyl, and then they're taking also heroin illicitly, the additive effect of those drugs can be fatal. So when we think about non-medical uses of drugs, you'll see from this 2012 publication of the survey, you'll see that pain relievers seem to be the highest use of drugs in terms of non-prescription use over the 10-year period shown here for people aged 12 and older. So pain relievers or pain management drugs are the highest used non-prescription medication or non-medical uses of drugs right now. If we think about the potentially fatal consequences of this, you'll see that in the early 2000s, the number of opioid analgesic poisonings that resulted in death, if you looked at death certificates, almost doubled in that period from 1999 to 2002. And we also find that in the same time period, poisoning from opioid analgesics surpassed both cocaine and heroin as the most frequent type of drug poisoning. You'll see some statistics there from Florida, where 3 times more deaths from prescription drugs than illicit drugs combined. And so we see this more and more. If you'll read the news, you'll see combinations of these. Now we find, certainly in large metropolitan areas, we see illicit drugs like heroin being spiked with drugs like fentanyl or fentanyl derivatives. And so this is something that has significant and severe consequences if it's not managed appropriately. So as part of this, because of the high abuse potential, but also the potential of fatal consequences from mixing medications or misusing these medications, it's very important to think about how we can assess risk in these patients and deter the abuse of these substances. When we look at ways to approach this, we have to think about it. I'm not a physician, I'm a laboratorian, but we think about it first from the physician's perspective, which is quite important in terms of how they're able to integrate risk assessment tools into their clinical practice. So in some cases, you have a multitude of tools that are available to you. But what's important for the physician to remember is that these tools for risk assessment, that's the first step, and then the care plan has to take into account these components of the risk assessment so that they can minimize the potential for misuse or abuse of the drug. So part of this is a physical examination, just assessment of what is the nature of the pain, and then also thinking about the history, and both from a personal history but also a family history of abuse. Is there a history of alcohol abuse in the family? Is there a history of addiction in the family? A psychosocial assessment is taken, and all of these are behavioral and environmental factors that are important to factor into the assessment of risk, because both personal or family history of drug or alcohol abuse seems to be one of the strongest predictors for the risk of abuse or misuse of these drugs. Another important thing to note is that addiction is rare in patients that are treated for acute pain with opioids. It really is not the addiction part in the short term. It really is something that can tend to develop over a long period of time, or perhaps that addictive behavior there is present prior to the treatment for acute or chronic pain. So some of the tools we have we being the clinical community we have these screening tools that assess potential risks associated with the opioid therapy. And there are some assessment tools or interview tools that we have that some of these are generally accepted. The first one being the screener and opioid assessment for patients with pain. There's the original and both a revised version. This is often referred to as the SOAP tool. There's another tool called the opioid risk tool. And then there's the DIRE instrument, or Diagnosis, Intractability, and Risk Efficacy instrument. The DIRE tool is clinician administered, and so it's designed to assess potential efficacy as well as harms, whereas the other tools are based on self-report. And I think this is an important thing to note, which is self-report questionnaires. Well, I mean, we can just say it candidly, people lie, particularly people that have addictive behaviors or are inclined towards these misuses of drugs. They tend to not be truthful with the clinicians, and so this is a challenge. And while these tools are deemed to be useful, there are definitely limitations, and the primary one being truthfulness of the patient reporting. So there, while the questionnaire, whether they're physician administered or patient self-reported tools, are important, there are other tools that can be used. So these interview tools are used for continual screening and risk stratification, but there are other things to do, such as pill counting. So we know that we gave you 30 pills and you're coming back to me and you're supposed to take one a day and you're out after 21 days. Well, that suggests that you're either sharing those or you're taking more than one pill at a time. And we can think about things like prescription monitoring programs that we'll talk about briefly, where in this case the prescriber, this is a report from pharmacies which tell you the prescriber, the date filled, how many pills were in that prescription, what's the pharmacy name and the city where the pharmacy is located. And what this allows you to do is a prescriber then can access this report based on the patient and find out if they're doctor shopping or pharmacy shopping and getting pills from multiple sources. One of the other tools is education regarding drug storage and sharing. How do we keep these pills away from our children or away from our spouses or siblings? And then also other psychiatric approaches as well. One last thing to think of would be abuse deterrent formulation. So adding something to the drug that makes it difficult to doctor the pill or crush it, or making it difficult to share, or if the drug is misused, then perhaps it can induce some sort of an illness. I think one of the approaches, not necessarily in pain management, but one of the more widely known approaches for abuse deterrent would be the Suboxone, where you have the antagonist naloxone in co-formulated with buprenorphine, so that if that Suboxone is abused, it will not allow you to get the high, or it could even induce a physical response as you displace the opioid from the receptors. So abuse deterrent formulations are one way also to get past this. So what a challenge with prescription monitoring programs is that they're not the same everywhere. Right, so in some cases they may go from scheduling Schedule 2 through 5 in non-controlled substances, as you see in the red states here on the map, where you go to some states where it's not widely used. The blue states you'll see are only Schedules 2 through 4, so it's not the same. And the other one is not all states share information across state lines. And so I think that, again, prescription monitoring programs are an important tool, but they don't necessarily solve the problem of inappropriate obtaining pain management substances. So one of the tools that is available that's an objective tool we want to talk about today is urine drug monitoring. And this is an objective tool to monitor abuse, misuse, or diversion from a clinician perspective. We know that there are some challenges in doing urine drug monitoring, but it does provide an objective measurement. It's very difficult to doctor, although there are some challenges there as well. But it detects the presence of a particular drug or its metabolites, and that enables us, if you couple that with some of the risk assessment tools and the clinical presentation of the patients, can give a physician a better sense of whether the patient is taking the medication as directed. Now, it's important to note that this still has a ways to go because it is used less frequently by primary care doctors, or in some cases, as we'll talk about, there are different tools that we can use for drug monitoring, and it may be that a primary care doctor is using a typical immunoassay-based screen that will miss the presence of many drugs that are used for treatment of pain, and so it may not be used as effectively as it could be. And the other limitation to the effectiveness of this tool is depending on the laboratory abilities, the testing laboratory's ability to detect what you're looking for. This goes back to many hospital labs don't have access to a mass spectrometry setup, and so if they don't have an LC-MS assay and they're not using a reference laboratory, they may only detect a small portion of the substances that are important for pain management. Another thing we have to think about from a clinician perspective, again, not from the lab perspective, is, well, when do they do the urine drug test? Based on some best practices that have been published, certainly initial testing is part of the risk assessment. It's important to find out up front before you start prescribing an opioid drug, is that patient, are they taking heroin or cocaine, or maybe do they have non-prescribed benzodiazepines on board? That right up front would be a red flag that perhaps this person is prone to misuse of drugs. Then after the initial testing, you can do later tests for monitoring, and that would be based on the initial risk level. And some of those factors would be the SOAP or other testing tools that we discussed earlier, or it can be maybe a standard procedure. So in this case, perhaps for a low-risk patient, you can do periodic eligibility, or you can do what we've listed here. As I've just been made aware of from interactions with our pain clinicians, that can be something as simple as a random selection, saying you come in and you flip a coin or roll a die, and if you get a 1 through 3, you get a urine drug test, and so that the patient doesn't feel that they're being singled out based on the interaction, but this is really randomized, and that they participate in the randomization, so they know that it's not rigged against them. But whether you use random selection or whether you use the self-assessment tools, the important part is to have sort of a uniform criteria that's risk-based, that enables you to explain to the patients how they want to approach this, how you want to approach the urine drug testing, and what your criteria are for determining when they would be tested. Some practices are now using in low-risk patients point-of-care screening, which are these urine cups that can detect a wide range of specimens. But in those settings or patient populations, there are still some limitations with immunoassay. So if point-of-care screening is used, then you should have at least one definitive test, which is, we would consider LC mass spec or mass spectrometry-based test. That should be done at least once per year, in addition to the point-of-care screening. So we'll move on a little bit. Once we get through the clinician perspective in terms of what is the role of urine drug testing or toxicology testing in pain management, and when should that testing be done, and it really should be done at least semi-frequently in conjunction with these other risk assessment tools. But what are the challenges that we have from a laboratory perspective? So if we think about the role of the laboratory, we have to think about what it is that we're being asked to do. So in this case, I put this statement, there's obviously no absolute assurance, but there is that sort of expectation. It's a burden and an expectation, right? It's good that the clinicians have a high degree of confidence in the laboratory, and they think that we can do just about anything, including the things that they see on television or the movies. But so the expectation here is that we need to give them absolute assurance that the drugs they're prescribing are being taken appropriately. And the way we're asked to do that, as we mentioned, is providing this objective indicator of a patient's compliance with the treatment regimen. And we do this through either a urine or a blood drug test. The other role, though, is we can't give them absolute assurance, obviously, so that's a little tongue-in-cheek. But that sort of rolls into the second piece, which is our role is to educate the physician. It's not just to give a number or a thumbs up, thumbs down that the drug is there. We really need to be able to talk with them and help them with interpretation if it's needed. For some providers, that support might not be needed, but we want to make sure that everybody's supported to the level that they need. We need to let them know about, some drugs, what the active metabolite is, and how that needs to be interpreted. But we also need to make sure that they're understanding the limitations of the analytical methodology. What are the shortcomings of an immunoassay, and what role does mass spectrometry play in this type of testing? So it's lab support for pain management is problematic. There aren't a lot of really good assays that are out there that are standardized and commercially available. Many of the immunoassays have problems that we'll talk our way through. The concentration cutoffs can be challenging. What constitutes a positive result? What should we be using the workplace drug testing cutoffs? Should we use forensic driving under the influence types of cutoffs? What cutoff should we use for a positive test, and are these applicable to the pain management population? Oftentimes the clinicians don't understand what's the difference. It's either there or it's not there. And then we have to think about adulteration. Now this is particularly challenging. I don't have a lot of information in this particular lecture, but it's something we don't normally think about it. If a patient comes to the emergency department, they're sick and they're not thinking about how to beat a drug test. They're just thinking about getting treatment, or they're not doing well. And in a lot of cases, they're non-responsive or certainly not coherent enough to be strategizing about how to beat a drug test. But in pain management, it's different. These are ambulatory patients that often are not in acute distress. They are patients in many cases that know there's at least a possibility of a urine drug test. And if they have smoked marijuana or used heroin or cocaine or a prescription drug that has not been prescribed to them, they know that they're going to be positive for that substance. And so we have to think about that. We have to think about things like pill shaving into the urine to give a positive test, or perhaps taking a bolus of drug immediately before so that their urine becomes positive. There are all sorts of things we have to think about in terms of manipulating the toxicology testing result that we don't have to think about in most other patient populations. So I think that is a real challenge that unfortunately I don't have a great answer for you in terms of how best to combat that. Another thing that's interesting about lab support is, there's now all this information. If we think about how to, in terms about specimen types that are available, there's lots of interest in dried blood spots or dried urine spots. We know that because of the adulteration, we want an observed collection, but there are privacy issues with observed urine collection, and most of the urines that are collected for pain management testing are not done so in a SAMHSA compliant environment for workplace drug testing, so that the toilet water is not blue, and they do have access to hot and cold running water, so they can dilute their urine or game the system. And so there are many challenges to those types of collection. But if you use oral fluid or saliva, that's something that can be observed. But there are some things that can make that challenging. There are, if you look in the lower left-hand corner of the slide, you see blood specimens there, and blood testing is an alternative, but the detection window is much narrower for blood, and it is invasive because it requires a phlebotomy event, and patients don't want that necessarily. And then we start to explore things like breath testing or sweat testing in pain management. There's not a lot of evidence that those are useful at this time, but those are options and things that we'll have to make sure that we're educated about as laboratorians, because once that information is out there, physicians will ask about it, and in some cases for it. So thinking about particular challenges with different matrices for pain management testing. Well, let's start with urine, because that's the most widely used sample. And when we think about the challenges with urine, some of it has to do with the specimen timing and variability. If it's a drug that's maybe taken once a day, if we think about relative of collection, because of the time of relative collection, right? So when did they take the drug versus when the time that we got the specimen? Did they drink a large container of water a couple of hours before collection and after they have taken the drug? And that can dilute it to below the cutoff. That gets back to the question of what's the appropriate cutoff for pain management. We already have touched on observed collection, and then urine is fairly easy to adulterate. And if you have some time on your hands and want to be amazed and perhaps entertained, just do some Google searches on different ways to cheat or beat drug tests. The adulteration options out there, just available through the internet, are for me, mind-blowing, the amount of thought that goes into trying to beat a drug test. So it would seem that the low bar or the no-brainer would be to say, well, let's go to a different type of matrix. Maybe we'll try with blood. But blood, as we've mentioned, is invasive. Many of these drugs have short half-lives, and so that's an abbreviated window of detection, and it would require, proper interpretation would require detailed or precise blood collection relative to the precise information around when the blood was taken. And there's no clear relationship between the actual concentration of blood and clinical effects. So if we tried to move this into the paradigm of more traditional therapeutic drug monitoring, we don't really have good tools for interpretation, and it's not clear that blood monitoring outside of patients that have renal dysfunction or aren't producing urine, I'm not sure that blood is really the way to go for most of these patients. And so again, the interest in oral fluid is increasing, but this is accepted in some quarters, but it's not 100% well characterized at this point. The oral fluid to blood drug concentration ratios are variable dependent on the drug that you're thinking about, and they're dependent on pH, they're dependent on protein binding. If you see some of the published data that are out here, there are wide ranges of the oral fluid to blood ratio between individuals. The paper I have here referenced is in 2009. Again, the cutoffs or the reference or therapeutic targets, it's not clear what those are. And also it's not uniformly understood how to collect the specimen. Some use a dilution into buffer and then calculate the dilution factor maybe from an optical measurement of a dye in the buffer, or in some cases it's weighing the device before and after. Some of them absorb the specimen. It's active collection, stimulated production of saliva versus a passive drool collection. So collection of the oral fluid or saliva is not standardized either, and I think that could introduce variability between laboratories in how to do this testing. And I think it's interesting, and it certainly helps with the collection in terms of observing and minimizing the adulteration risk. But I do think in my opinion, it's not quite ready for prime time yet, but I know that it is being implemented in many different settings. So in addition to the different matrices, I mean, there are all kinds of types of samples we can test, but we also have to think about the different methods. Right, so we have here some point-of-care kits by immunoassay, and then we have liquid chromatography, and we have gas chromatography coupled with mass spectrometry, and all of these are different settings that we can use to detect the drugs. And we have to take into account, again, we have to be able to understand ourselves what these methods are capable of, but we also have to be able to articulate what are the limitations and what's the best approach for a particular patient population. So there are multiple technology platforms. Each one has its own technical difficulties, and the ones that are most common are immunoassay screening, gas chromatography, mass spectrometry, and then liquid chromatography, mass spectrometry. If we think about immunoassays, one of the challenges is that the specificity of detection varies with the vendor. For some things, immunoassays tend to be somewhat specific. Where we have something like a benzoleconine assay for cocaine. Well, that's pretty standard, but other assays like benzodiazepines, they're calibrated with a different standard for whatever the qualitative cutoff is, and that means that the level of cross-reactivity for the wide variety of benzodiazepines varies from vendor to vendor on what you may or may not pick up. The other thing we have to think about is what do they detect. They're not, in most cases, not specific to a particular drug or metabolite. Benzoleconine is more the exception than the rule. And in most cases, if we take an opioid assay, for instance, it primarily picks up morphine, codeine, and then 6-monoacetylmorphine or heroin. Right? So it picks up those particular substances, but then it doesn't really detect oxycodone at a normal concentration. It's a very quite high concentration. And so if we move to the middle of the slide here, we do see that oxycodone doesn't really react with the opiate assay at low concentrations, but at very high concentrations, at least say in our laboratory, at greater than 10,000 nanograms per mil, whereas the cutoff for morphine would be 300 nanograms per mil. it would take 10,000 nanograms per mil to cross-react. But that is possible, right? So we don't really know that. It could be a very high concentration of oxycodone, it could be hydromorphone, or it could be morphine or even heroin, and we don't know the difference. And it's a very big difference between somebody taking Tylenol with codeine and somebody who's shooting up with heroin, right? So the non-specificity is a challenge. Then we have a couple other examples here on the slide. One is fenofibrate and amphetamines. And so fenofibrate is, it lowers cholesterol like statins, and it's taken at a relatively high dose, and so it can get into the urine and cause, it's been published that it does cross-react with amphetamines, and we have indeed seen that in our lab in a cardiac population. Then we have naloxone. We'll touch on this a little bit more in a couple of slides, but we have seen that if someone is being treated with naloxone as an antidote or antagonist for the opioid receptor, if it's in the urine or blood at a high enough concentration, it will cross-react with the assay. And again, somebody with naloxone, I mean, I guess technically you don't want them to have that. That means they're being treated for opioid overuse, but at the same time, that's if they were treated with naloxone, that's a little bit different than if they're abusing an opioid drug. And then with immunoassays also, we're dependent on this qualitative cutoff for most clinical immunoassays. It does have the capability to do quantitative testing, but most toxicology screens via immunoassay are done qualitatively. With gas chromatography mass spectrometry, this is the gold standard for toxicology testing, and so it's used primarily in confirmatory testing. And this is useful because it can provide both structural, qualitative information for identification, and it can also give quantitative information. But many labs don't have access to the equipment. Especially as we move forward, gas chromatography mass spectrometry in a hospital laboratory is used less and less. For most of our confirmatory testing, we do send that to a reference laboratory. In order to do gas chromatography, it also must be, the substance must be derivatized to make it volatile if it's not naturally volatile, and so that requires a lot of specimen pre-treatment, extractions, derivatizations, and follow-up extractions. And in a lot of cases, you know, perhaps you get a number. It does have the ability to provide quantitative information, but what does that number mean? If we, you know, what is the cutoff that's appropriate, and what is the number that represents compliant versus non-compliant? And I don't think, while some have posed solutions to this, I don't think that there's been an entirely effective solution that I've come across. And last, what's at least a little bit more accessible would be LC, or liquid chromatography mass spectrometry. Now, this does, I place here that it says even more limited access to equipment, although I would qualify that by saying that more and more hospital laboratories are getting access to at least part-time use of LC tandem mass spectrometry. But the difference between GCMS and LCMS is that with gas chromatography mass spectrometry, there are commercially available libraries. So there's a well-established library that you can use for matching and be able to identify drugs. But with liquid chromatography mass spectrometry, those libraries are not widely available, and you must really develop your own. Although that is changing, some of the vendors are working to make these tools available, but they're not widely used at this time. And manual data review is needed, right? Because there are shifts in the chromatographic retention time with liquid chromatography that are maybe more pronounced than you would see in gas chromatography. But again, LC tandem mass spectrometry can give quantitative or qualitative data, but you must determine, again, what are the criteria for compliance or adherence. So we're going to talk a little bit more in depth about two of the technologies. One is immunoassay, and so you'll remember that with immunoassays you have the antigen binding site, and so you're not looking at the whole molecule. In this case, you're looking at a structural region of the molecule, and because you're having that physical interaction with the protein binding site, or the region of the protein that has an affinity for that particular structural site, there are molecules that would be different and have different effects, but may have that epitope or protein binding moiety. And so that can be challenging. One example I wanted to give you, and it calls back to the naloxone cross-reactivity, is we had this case study we published in 2010 where a small child was found abandoned, unfortunately, and they were admitted to the emergency department or transferred to the emergency department at Johns Hopkins with decreased mental status and possible hypothermia. We did use opiate immunoassays to do urine toxicology screening, and the first assay upon admission was negative, and after treatment we then found that the second immunoassay was positive, and the confirmatory testing for that positive immunoassay was negative. In other words, we did not detect, based on GC-MS, either codeine, morphine, heroin, or any of the other oxycodone or hydromorphone. So there was something that was causing that immunoassay to be positive, delayed from when the child was found. And it was a real head scratcher to find out what was going on with this patient. What we did find is, on a little more digging, is that patient was given naloxone. They were given a bolus just before the first urine was collected. So they got a shot, right? But not the urine. It was not far enough away from the urine collection so that it would have made its way in, to be cleared into the urine just yet. But then after the first urine was collected, in addition to the bolus, the young girl was given a naloxone infusion. And so in digging a little bit, we found that at very high concentrations, naloxone can cross-react with the immunoassay. We confirmed this experimentally in our laboratory. You'll see here that indeed, based on a follow-up report from the company, at 6,000 nanograms per mil or micrograms per liter, it does turn the immunoassay positive. And so we sent the 2 specimens from the young patient for quantification, and what did we find? We found that the first was about between 300 and 500 nanograms per mil, and that the second specimen was at almost 10,000 nanograms per mil, which obviously would cause the assay to turn positive even though there was no opioid drug on board the patient. So it would seem then the answer is, well, let's just do mass spectrometry, and there are different ways to approach this. We can do selective reaction monitoring with tandem mass spectrometry and a triple quadrupole. Some laboratories are moving more toward time of flight or high resolution Orbitrap mass spectrometry. I think the challenge here is that with triple quadrupoles, that's equipment that more hospitals have access to, but it only differentiates at nominal mass. Whereas the time of flight or Orbitrap instruments, they can get high resolution mass out to 3 and 4 decimal places. When we look at the different modes, we want to think about targeted versus untargeted screening. Do we want to generate a number, or do we want to report just a positive or negative? I will tell you in our reference laboratory, just for our physicians, we do mass spectrometry-based screening because of the selectivity, but we only report positive and negative results. We do not generate a number that we send to the clinician. And it's important when we're thinking about the mass spectrometry to think about the trade-offs. What are the number of compounds that we can detect, and with what degree of reliability? What's the length of analysis? What's the sensitivity and specificity? And those are challenges that we have to think about as we're trying to get this into routine clinical use. The other challenge with the mass spectrometry-based testing is that there are many compounds that are isobaric. We just show one here, set here with the hydromorphone and morphine, both of which cross-react with immunoassay, as you can see. I apologize for the darkness of the slide. I guess it didn't translate from my slides into the viewer. But what you'll also see is that they have the exact same mass out to 4 decimal places. It's really just a structural isomer. So they fragment very similarly. And the only difference between these two is chromatographic retention is slightly different. And that's really important to, well, also there's I shouldn't say that's the only difference, there's also a functional group difference. And that's what contributes to the chromatographic retention retention time difference. And so the way we approach this is we get isotopically labeled standards for both compounds, and we run them so that we know on that particular chromatography column where each of the drugs is eluting, so that we can differentiate one from another. But it is very difficult, because even monitoring the fragments, they tend to look very similar. So aside from technical challenges, then we also have the challenges of interpretation. And it's important because, again, let's go to it from a lab perspective and from a clinician perspective. From a clinician perspective, there are really three broad categories that we have to think about. Number one is that the prescribed drug is not detected, or in other words, we've prescribed the patient Oxycodone, and we are not seeing the Oxycodone present in the specimen. That indicates that there's a chance that they're either diverting the drug or they're hoarding the drug and not taking it as prescribed. A second category would be where we detect an illicit drug, so that we find that they're exhibiting drug abuse behavior. And then last, that a non-prescribed scheduled drug or a drug of concern that may have synergistic effects with the opioids, particularly in the area of respiratory depression, is detected. And so if you think about it from a clinician in these broad ones, an assessment of adherence, and then also non-prescribed substances in the last two categories. What we find is an absence of the prescribed drug and a detection of illicit drug should require immediate action in terms of referring the patient to substance abuse treatment. Also, from the clinician perspective, and it's incumbent on us as the laboratory to be able to communicate this to physicians, is to think about the retention time or how long these drugs stay on board. The windows of detection are this period, when we say that, are the period of time after drug administration where we can actually detect the drug. If we have some examples, most opioids we really see 2 to 3 days, but amphetamines we'll only see for about 2 days or 48 hours. Cocaine and heroin have extremely short half-lives, and we'll see them 24 to 48 hours. Oftentimes it's closer to 24 hours for these particular drugs of abuse. And something like marijuana, if that's of concern to the clinician, will stick around for 3 to 6 weeks. The other one is thinking about the metabolism. So here you see the metabolic pathway of morphine and related compounds. And one of the things that is challenging is, if you look at this particular slide, we see morphine, which can be prescribed as MS-Contin, but we also know that hydromorphone and hydrocodone can also be prescribed. And so you'll see that if we see hydromorphone in the sample, that while it's a minor metabolite, if somebody's getting high-dose morphine, you may see the hydromorphone. And then the question becomes, well, if you see hydromorphone in the absence of morphine, what is responsible for that pattern? So it's really important to be able to talk through those metabolic pathways with clinicians to see what's consistent. It's very difficult to say definitively, based just on urine drug testing levels, that a patient is compliant or non-compliant. But it is possible to say whether a pattern that you're seeing based on the metabolism is consistent with the compliant behavior or non-compliant behavior. Another thing to consider, this direction. Another thing to consider when you have this is measurement of the metabolites. One of the things that I mentioned earlier in terms of looking at the interpretation of the results, I said people can shave pills into the urine. So somebody could know they're being tested, they could be diverting their medication, but they know that they need to test positive. So they could take a fingernail or a penny or something and shave bits of the drug into the urine cup. Now that will likely give, for an immunoassay, it would give you a very hot or very strong positive for this. But what we would see then is, if you were pill shaving, for instance, you would not see the metabolites. That only happens if somebody's ingesting the medication. And so being able to detect not just morphine, but normorphine and morphine glucuronide would certainly enhance the ability to differentiate between pill shaving and actual ingestion of the medication. We'll touch briefly here is benzodiazepine metabolism. And if you look at the 3 red circles, each of these, so the temazepam and oxazepam are drugs that are metabolites of diazepam, but they're also drugs that can be prescribed on their own. And it's important that clinician know that if you detect oxazepam, it is possible that you're just seeing the metabolism of the prescribed drug diazepam, and they're not going out and illicitly obtaining a different substance. And that's important to keep in mind. The last thing I want to touch on with interpretation is quantitative urine toxicology. So I mentioned earlier that you can generate a number with any of the technologies where it's immunoassay, but more commonly with mass spectrometry-based testing. And there is some degree of discussion around whether or not that those numbers can be used to confirm adherence or compliance with the regimen. So I'd like to point to 2 studies. There are people that advocate for this and argue for it. And so there are a couple of published studies that tried to demonstrate that this is at least feasible. And so this is a study published in 2009 around an algorithm to adjust mass spectrometry-based values. And they're looking at distribution. And in this study, I provide the reference so you can go look up the study itself if you want. But I'll give you the short version, which is in a set of normal patients that are not being treated for pain. This was an inpatient study so that the administration of drug could be carefully controlled. Differential metabolizers were excluded, right? So they were tested for their cytochrome P450 metabolism, and only wild-type metabolizers were included. These were patients that received a naloxone block, so they were administered oxycodone in a careful way, but such that they wouldn't receive any of the analgesic or the high that you would get from the drug, and that they would be kept safe, of course. And they weren't taking any additional medications that might induce a drug-drug interaction. So this is sort of what you would say is the ideal best-case scenario, that everybody metabolizes the drug relatively the same. And so the goal here was to distinguish between groups A, B, and C in doses, carefully administered, in 80 milligrams, 160 milligrams, and 240 milligrams. And so it was a very carefully controlled, well-performed scientific study. And when the investigators went to do the analysis, they compared the medians, the statistical medians of each of the 3 populations. And what you can see in this, as I put by the red lines, that here are the medians, and when they looked at they did the 95% confidence interval around the median, and they found that the median, the confidence intervals for the medians, when they took a conservative approach, did not overlap. In other words, they're able to confidently distinguish between the medians of the 3 populations. But the challenge is here that we don't treat medians and we don't treat statistical populations, we treat individuals. And what is obvious from just looking at these distributions is that the distributions of the 3 populations overlap significantly. And so if you were able to look at this, and in fact, when we develop target ranges or reference ranges in the central lab, this is often around not the 95% confidence interval of a mean or median, but it's around the distribution of the population, right? Our reference intervals try to encompass 95% of the patients tested. And now you look at that great population overlap and you would look at just a single, this is an example of one thing. Based on that result, could you really tell whether that patient was taking, or differentiate between a patient taking 80, 160, or 240 milligrams of the drug? And the answer of that would be no. By itself, you would not be able to tell that based on the number. Now, a similar study was done with hydrocodone, this time using an immunoassay, but I'll spare you most of the details. It was done very similarly, an ideal population. And in this case, what you'll see is there's less overlap between the populations, but the result is the same. Statistically, the median and their confidence intervals do not overlap. But when you look at these populations, you'd see that there would be difficulty with certain values in differentiating between 20 or 60 milligrams or 60 and 120 milligrams. So while you can statistically describe the population and say, if you fall in this range, that is consistent with the particular dose, you couldn't say whether they were taking a different dose or not. It would be very difficult to use that to tell you whether or not they're misusing the drug, I believe. And that's not how we evaluate tests. We don't look at the median or confidence intervals around the median. What we look at is how well we identify patient populations. And we think about things like sensitivity and specificity, or positive or negative predictive value. And so a colleague of mine, Doug Stickle, this reference is wrong. It's a paper actually published. It was electronically available in 2012, but it's if you look for the actual reference for this now, it's in January of 2013 in Clinical Biochemistry. And what they did was they took the histogram in the Oxycodone paper from 2009, and I don't have a better way to say it, they reverse engineered the figures so that they could figure out the number of patients or number of drug specimens, and then try to do some calculations based on the results that they were able to extract from the paper. And then what they did was construct 6 different receiver operating characteristic curves, or ROC curves, which is a more standard measure of the ability of a test to characterize one population versus another. And what you'll see here is in the upper left-hand corner, you're using the lowest dose as the reference population and then comparing to the mid and high populations. On the right, the upper right corner, you do the same analysis but using the middle dose as a reference population. And then in the bottom panel, what you'll see is using the highest dose, or the C population, to compare the lowest and middle population. And what you'll see here is that best case, what you're getting is an area under the curve of just under 0.8, which is not good. If we think about a good value for area under the curve, if it's 0.5, as you'll see in the bottom panel, that's basically a coin flip. And if you look at, it's close to the 0.55, I think was the actual one, and differentiating the highest dose from the middle dose, using the high dose as the reference population. And you'll see the best that was done here was just short of 0.8. Again, and if you try to optimize getting to the optimal sensitivity versus specificity, you'll see in the upper left-hand panel a sensitivity of 0.74 and a specificity of 0.75 if you optimize. But that's not really how we do things. More likely what we would do is optimize either sensitivity or specificity. So in this case, we would say we would like to detect all the people in group A. If we adjust the cutoff so that we will catch 95% of the population, so we have a 95% sensitivity. What is the specificity for that? In other words, what are the odds if we structure it so that we include 95% of group A? What are the odds that we exclude groups B and C, those that are taking different doses than in group A? And you'll see that those odds are quite low. The specificity is 0.14 and 0.27 for the A group, if you use the A group as the basis. If you go to B, you'll find not much better. The best one was actually using the C, or the high dose, as the basis group, and trying to differentiate that from the lowest dose group, or group A. And you'll see the specificity at 95% sensitivity would be 40%. And so the odds for exclusion are not terrific. In fact, everything is under 40% odds for exclusion. So it is not a great way to differentiate between populations, other than doing some descriptive statistics. Again, it's not any better than saying this result can be consistent with this particular drug at the dose, but it has to be used in conjunction with risk assessment tools and not as standalone. There are no quantitative, at least as it stands, with quantitative urine drug levels. So with final thoughts, what we'd say is that, a misunderstanding of results or wrong results can lead to discontinuation of treatment for patients with real pain. This is really important to get this right and to make sure that things are interpreted correctly. And in order to do this, it's vital to have an ongoing dialogue with pain management physicians, both so that we can understand their needs and practices, but also so that we can communicate to them what the limitations and appropriate testing practices are. It plays an important role in pain management. It's used to confirm patient compliance with treatment guidelines, and also to minimize potential for abuse, diversion, and any risks with specific drug combinations. With that, I appreciate your time and attention, and I'll be happy. Oh, I jumped the gun. I'm sorry. One thing I did want to point out before I turn it over for questions is that there are laboratory guidance documents coming. We do have two documents I want to call your attention to. The first document is an evidence-based lab medicine document from the Academy of AACC, and this was done over the course of 3+ years, where the results were reviewed from all the literature reports. It was then done systematically. We graded the evidence. We opened it to public comment. It was presented both at the American Association for Pain Medicine as well as the American Association for Clinical Chemistry, AACC. Both laboratorians and clinicians contributed to the document, and this document should be available by the end of the year. Another document that we hope to have available by the end of the year is a consensus guideline, again from both laboratorians and clinicians, from the Clinical Lab Standards Institute, and this is done. Many of us are serving on both of these committees in order to harmonize the guidelines, but this document is more of a consensus document around what is best practice based on expert opinion rather than scientific literature, because the end version is, in many cases, for many of the questions we have, the scientific literature is just not complete and is quite sparse. And now with that, I'm happy to turn it over to questions, and again, I thank you for your attention.
Dr. Clarke, thank you for that informative presentation. Now, before we get started on the question and answer session, I would like to remind our audience how to submit questions. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. Okay, Dr. Clarke, our first question is, given the limitations of immunoassay testing, what is the benefit if using this type of testing in pain management patients versus going directly to mass spectrometry-based testing?
Thank you for that question. So I think one of the challenges with immunoassay, as we pointed out, is that it's not a definitive type test, but it is easy to access, it's automated, and it's quite low cost compared to chromatography mass spectrometry. And so I think, particularly in a low risk population, I can see the value, as we pointed out in the slides, of having doing more routine immunoassay testing with less periodic mass spectrometry based testing. In a high risk population, I would say, again, this is not evidence based, but closer to consensus opinion. I guess maybe a consensus of one at this point, but I would think in a high-risk population you would want to go directly to chromatography mass spectrometry-based testing so that you can identify the specific substances and make sure that you get that answer right up front.
Dr. Clarke, what is the biggest challenge for the laboratory in providing support for pain management patient care?
So I think the biggest challenge is still making sure that clinicians understand the limitations of what the laboratory can do. I think that we've made a great deal of progress in terms of our ability to support the clinicians, and we've done well in terms of engaging the clinicians. But I think it's really important to be able to communicate that, and it's really the dialogue and making sure they understand that we cannot give them the final stamp of approval, that they have to use their clinical judgment and the risk assessment tools in conjunction with this. So it's really hard, I think, to make sure that the clinicians and the laboratory is on the same page, or that they're on the same page. But I think that that's an area, while it's the most challenging, I think it's an area where we have the opportunity to make great strides, and we are doing so with the guidelines and just with current practice.
Dr. Clarke, thank you again for your informative presentation and questions and answers. Do you have any final comments for our audience?
Thank you, Christina. Just the final comment is that I think that while we've made great strides, I was just getting ready to say on the last one, we still have a ways to go, and it's going to require a lot of cooperation. But I think that through more technology developments and better clinical studies, we can really work together to find better ways to, from the laboratory perspective, to support the clinicians, but most importantly, patients. So again, thank you for your time and attention.
Thank you again, Dr. Clarke, and also thank you to LabRoots for making today's educational webcast possible. Today's webcast will be available for on-demand viewing through February of 2017. You will receive an email from LabRoots alerting you when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. Thanks for joining us, and we hope to see you next time. Goodbye.